Hello class. So yesterday we reviewed, or you guys learned, steps to medication administration, and certain things never change. I'm going to briefly go over the things that remain consistent regardless of the route. And in the future slides, I will just refer to them as doing the basics, okay? So for the sake of time, I will not mention them for each different route, but I will say you will do the basics. And then for this particular route administration, I will go over the steps for that administration route in particular. Okay, so what we discussed earlier was you will, so you always are doing your 3 checks. You always are doing your 11 rights. You're also checking for allergies, checking the expiration date for any medications. You're gathering your supplies. You're knocking on the door. You're coming in. You're introducing yourself. You're washing your hands. You're putting on PPE if necessary. You're identifying your patient. You're explaining to your patient exactly what you're doing and educating your patient at that time on the medication as well or any adverse side effects. You're doing any type of assessment, so all that stuff falls into your 11 rights, okay? Then you are doing specifics for the particular route of administration, okay? So for injections, there are certain things that never change as well. So you are always opening up the new valve. If it is a new valve for a multi-dose, you're going to flip that cap up with your thumb, open it up, scrub the hub for 30 seconds with an antimicrobial, which is usually alcohol pad. Allow that hub to dry. If it's a multi-dose, you are injecting the same amount of air into the valve that you are withdrawing the medication amount that you need to withdraw. Okay, so you're injecting 1 ml of air, you're withdrawing 1 ml of medication. If it is a single dose valve, you do not need to inject the air, you are only withdrawing the medication. Okay, but you still are scrubbing that hub, you still are allowing it to dry. Okay, those things never change. All right, some other things that never change with injections. You do not want to massage the area. You want to instruct the patient not to scratch or rub the injection site. Any event that there's a small amount of blood or something like that, just blot it with a dry gauze. No pressure, just a very light, gentle blot of the skin. Okay. You may need to mark the site, or definitely you are recording the site of injections because the injection sites must be rotated. Okay, you cannot, if this is an injection that someone's receiving on a routine basis, you cannot administer into the same site each time. You're going to damage the patient's skin and it's going to prevent the absorption of the medication. Okay, after you have completed your injection, you are engaging the safety immediately. And nowadays, all needles have safeties. Some in our lab may not have safeties. When you go to the clinical sites, you will see all needles have safeties. Engage the safety, that is to prevent any accidental sticks or injuries to yourself or others. Dispose of the needle into the sharps container. Remove your gloves. Wash your hands. Document the administration. So you're documenting the medication, your assessment, if as well as your site of injection. Okay, and you're always going to come back and evaluate, make sure there was no allergic reaction to the particular injection, or look for any adverse side effects to the medication. Okay, so those are things that never change. And on the future slides, I will say you are doing the basics and you will know all of the steps I'm referring to. On this particular introductory slide, I want to review subcutaneous and ID injections. Okay, ID as in intradermal or subcutaneous as in sub-Q injections. So we did do this in class, but just so that it is comprehensive, I'm going to review them these two methods here, and then we'll begin for our intramuscular slide as well as our IV and other routes of medication administrations. So for an ID injection, you are pulling the skin taut. Okay, the bevel of the needle must be up. So the bevel of the needle is the little slanted opening at the very tip of the needle. So you want the bevel up because when you inject the solution, it's going to be directly under the skin, right under the dermis, and you should see a little wheel appear. So you want that solution to come up right under the layer, the very top layer of your skin, okay? And for that to happen, the bevel must be up. The needle is only going to be inserted 1/8 of an inch, so very slightly under the skin. You're not going to have a large portion of that needle under the skin, just barely under the skin. The length of the needle for our intradermal injection is 3/8 to 1/2, and the gauge is 26 to 27, and this is according to your textbook. Okay. The dose, the maximum dose given ID would be 1/2 milliliter or 0.5 mLs. Okay, and the angle ranges from 5 to 15 degrees. So that needle looks as if it is flush against your skin. Okay. You do not want that needle to be higher than 15 degrees. You will go too deep and it will not be an intradermal injection, but it will go into the subcutaneous layer. All right, moving along. For our subcutaneous injections, our sub-Q injections, the gauge is between 25 and 30. Oh, yes. And so the gauge is the diameter of the needle. So I want to make sure you guys are not confused. The gauge is not the length, it is the diameter of the needle. The length is measured in inches. Okay. Now the length is 3/8 to 1 inch for a subcutaneous injection. And so this is according to your textbook. The most common gauge and length used for adults is 25 gauge, 5/8 inch. Okay, so that's pretty important to know. Okay, the dosage for a subcutaneous injection is 1 ml or less. So this dosage is pretty small as well. Okay, so you determine the length and the gauge of your needle that you select for your subcutaneous injection according to the size of your individual. And you also determine the angle in which you are going to administer the medication according to the size of the individual. So you want to administer a sub-Q injection either at a 45-degree angle or a 90-degree angle. So for our patients who have very little adipose tissue, so for someone that's very fit and does not have a lot of fat tissue, or someone that's very frail and may just not have a lot of fat tissue, so some of our little elderly men and women may not have a lot of adipose tissue, then you want to administer at a 45-degree angle. You are still pinching the skin for a subcutaneous injection, okay? So the proper position for a subcutaneous injection is to pinch the skin. If you have someone that you can pinch an inch, so if you can pinch an inch of subcutaneous fat or adipose tissue, you want to go at a 90-degree angle, okay? So just remember, pinch an inch, 90-degree angle. So injecting the solution in the proper tissue will help with absorption of the medication. So you don't want to go too deep and be in the muscle with a medication that is administered subcutaneously. Okay. And I also want to mention that with any medication valve, if you're withdrawing medication from a valve with a needle, it must be on a flat surface. You should not be holding it up in the air. It should be on a flat surface. And you want to inject the air into the space at the top of the valve where the air is, not into the solution. Then you want to invert the bottle and submerge your needle tip in the solution and withdraw solution, avoiding withdrawing any air in your syringe. In the event that you do get air bubbles in the syringe, you can push the solution back in to the valve and move your bevel of your needle down a little bit so that it's submerged further into the solution and withdraw the correct amount. Another technique to relieve bubbles is to take the syringe out completely, tap on the needle, get the bubbles or all the air to the top, push the air out, and hopefully you have the correct dose, but in the event that you do not, you will have to just withdraw a little extra medication to make sure that you have the correct dose. Okay, as I mentioned in class, oftentimes I will withdraw a little extra medication. So when I remove the bubbles, my amount is exactly what I need. All right, so you are welcome to write down any questions, bring them to class, or email me in the event that you have any questions about anything I just reviewed. Intramuscular injections or IM injections. So these are our 3 common injection sites and the length of the needle. So there are basics for all injections, which include removing the cap if it's a brand new valve, a multi-dose valve, scrubbing the hub for 30 seconds, allowing it to completely dry, selecting the correct needle, syringe, which you're about to learn now, removing the cap of the needle, or you may have a blunt cannula, which is just for the purposes of removing the medication, and then you are switching it out for the correct needle size. And you may see that at the hospital in acute care next semester. Place the valve on a flat surface, then insert the needle to withdraw the proper amount of medication. And so we talked about the multi-dose. We talked about how to withdraw medication from a valve. So you're injecting air into the multi-dose, you're withdrawing the medication, inverting it and withdrawing the medication, right? And we also talked about a single dose you do not need to inject air into. So we won't go over those things again. So our vascus lateralis, the needle length is 5/8 to 1 inch. Our deltoid for children, 5/8 to 1 inch in length. So our shorter needles. And then for the deltoid for the adult, we have a range of 5/8 to 1.5 inches. And for the ventral gluteal for adults, 1 inch to 1.5 inch. So these are the correct needle lengths for the correct sites. When administering an IM injection, you are doing all of the basics. Then you are selecting the correct needle. So you need to select the correct gauge and length, as well as the correct syringe size, because for our IM injections, we can deliver a larger amount. So between 1 and 5 mLs is usually an acceptable range for an adult. And for a child or an older adult, 1 to 2 mLs IM is usually an acceptable range. Okay, so the gauge for IM injection ranges from 18 to 25 gauge. So the lower the number, the larger the needle. So if you recall the needles I showed you in class last week, the IM injection was the larger needle. So the ones you could probably see from the back of the classroom, that is the IM needle. Okay, so an 18 gauge to a 25 gauge is IM. And the length ranges from 5/8 to 1 1/2 inch. Okay, IM. So the longer needles are IM injections as well. So a 25 gauge, 5/8 length needle can be used for both subcutaneous, as well as IM injections. Okay, so the the length and the size of the needle has to do with the solution, the type of solution that you are administering. Okay, so the viscous or the thickness of that particular solution will require a larger gauge. In addition to the length will be determined by the size of your patient. So muscle mass, body mass, all of those things come into play. Okay, so that's why that 25 to 5/8 may be used for both. So depending upon the size of your patient for IM injection, they may can use a smaller needle if they don't have a lot of muscle mass. In general, 1 to 5 mLs is the acceptable range for an adult. Okay, and I mentioned this already, 1 to 2 for children or older adult. Okay, IM drugs can irritate the subcutaneous levels of tissue, so therefore a Z-track technique would be recommended for this particular injection, and you will learn the Z-track method in lab. But for purposes of our lesson, you are pulling the skin down and towards one side, 1 to 2 centimeters, spreading the skin taut. You are going to inject the needle in on a 90-degree angle, preferably. If you have someone that is thinner or has less muscle mass, such as an older adult or a child, you might want to use a 45-degree angle. You're going to inject the medication slowly. After 10 seconds, you will withdraw the needle steadily on the same angle that you inserted it. And at the same time, you are releasing the skin. This displaces the tissue back to the normal position and allows the IM medication to be locked into the muscle, avoiding irritation of the subcutaneous tissue or skin layers. You are not to massage the site. You are not to rub and scratch the site. So instruct your patient of that after administering the medication. Okay. Now, an alternative method to the Z-track method, an alternative IM injection technique would be to take 2 fingers, usually your thumb and your index finger, spread your skin taut, so you are flattening out the skin and holding it tight. You are still going in at a 90-degree angle, preferably 45-degree if it was someone with less muscle mass. You're injecting the medication slowly, waiting 10 seconds, withdrawing the needle, and releasing the skin. Okay, and then we are doing all of the basics after our IM injection, right? You always want to engage your safety for any type of injections. You also want to remove your glove, dispose of your needle into the sharps container, remove your gloves, wash your hands, evaluate, document. You want to do all of these things and monitor for signs of adverse reaction. Okay, so here I have pictures of the 3 most common IM injection sites and how to locate them. So for A is the ventral gluteal site. It is located by placing the palm of your hand over the greater trochanter. So that little ball of the hip, your palm of your hand is going to be there. And the index finger is toward the anterior superior iliac spine. That's where your index finger will be. Then the other 3 fingers will align with the iliac crest, making a V in between your index finger and your middle finger, and that is where your injection site will be. I have the injection site highlighted in yellow. Okay, so our next injection site B, vastus lateralis, is identified by dividing the thigh into 3 portions. So you'll put one hand at the top of the thigh, laterally, one hand at the bottom, right above the knee, laterally, and that middle portion of the thigh, lateral middle portion, is where that vastus lateralis injection site is. So I have the highlight of yellow, and the injection site is actually indicated in blue. Okay, and for picture A, the injection site was indicated with a blue dot. Okay, so we have C, injection site C, which is our deltoid. So how do we find a deltoid? Glad you asked. So you're going to palpate the lower edge of the acromial process. So that's a little knot right there at the top of the shoulder. Typically, you are going to put 2 to 3 fingers below that acromial process, and your injection site is right there in the middle of that shoulder. Okay, so that is where your deltoid muscle is. So you want to go right there in the center of the deltoid muscle, approximately 2 to 3 fingers down from the acromial process. I have a blue triangle there highlighting the injection site, and the injection site words are highlighted in yellow. Intravenous medication administration delivers the medication directly into the bloodstream, and it has an immediate onset, making this the most dangerous route of administration. It is often used in emergencies. When a nurse is administering intravenous medication, she must perform hygiene and wear gloves to prevent infection. The nurse should assess the IV site, insertion site, and she's looking for signs of infiltration or phlebitis. Infiltration is when the fluids leak in the surrounding tissue around the insertion site. This causes the insertion site to become cool to touch, hard, and swollen. Phlebitis is when the vein becomes inflamed, and this inflammation causes the skin to become red and warm. In both situations, the IV must be discontinued, that site cannot be used, and the nurse must insert a new IV line in another location. So if the nurse assesses the IV insertion site and there's no signs of infiltration or phlebitis, and this site is safe to use, the nurse must then unclamp the saline lock, also known as a hep lock. Scrub the hub for 30 seconds, or according to the facility's policy. Flush the saline lock with normal saline prior to and after administration of IV fluids or IV medications according to facility policy. And she must always reclamp the hep lock line or saline lock line and cover it with an antimicrobial cap when not in use. So here are some different types of administration methods for intravenous administration. So first we have continuous. So intravenous solution can have a rate such as milliliters over hours over a defined period of time with IV fluids such as normal saline or half normal saline. And they may run continuously at a defined hourly rate. Medication can also be added to these bags. So the physician may have ordered 3 liters at 100 mLs an hour. So that solution will run continuously until all 3 liters have been administered. Then you can have IV push. So IV push can be administered directly into the hip lock or saline lock. This involves a single injection of a concentrated solution directly into the venous line. You will refer to your drug book to determine if the medication being pushed must be diluted. Sometimes dilution is necessary, other times it's not, and the time frame in which the IV medication must be pushed will be determined according to the medication and what you have found in your medication drug book. A piggyback or intermittent medication, sometimes the medication is piggybacked into a continuous IV infusion, and this infusion is usually in a smaller bag of medication between 50 and 100 mLs typically. Occasionally, it will go up to 250 mLs. This medication is usually ran over 30 to 90 minutes and is often administered via pump. So on this slide, it has step by step exactly how to administer IV medication. So we covered the first 6 bullets on the prior page. So you're assessing your IV insertion site, removing the antimicrobial cap, scrubbing the hub, cleansing with antimicrobial swab, usually an alcohol pad, allowing the hub to dry, connected saline syringe, unclamp the saline lock, also known as a hip lock, flush the saline lock according to your policy. Typically, this is 3 mLs of normal saline or 5 mLs of normal saline. Remove the cap from the syringe with the IV push medication in it. That should already be prepared, whether it was diluted or needed dilution or not. Remove the cap from the IV tubing and connect it to the saline lock. Then administer the medication as ordered per policy. Flush after the medication or infusion is complete. Clamp the saline lock, also known as a hep lock. Scrub the hub with an antimicrobial swab. Apply an antimicrobial cap. And I mentioned this on a previous slide, but the antimicrobial cap is to prevent infection, so it keeps bacteria from growing on that hub of your saline lock or your IV line. Discard gloves, wash hands, document date, time, medication name and route, flush solution, amount, tolerance, condition of insertion site, and your rate if you're using a pump, and the reason for administration of this medication. Then you want to evaluate the patient's response to the medication, and that should also be documented in your notes. We'll talk about how to apply transdermal patches or topical medications. So wear gloves to remove an old transdermal patch, and also wear gloves to apply a new transdermal patch. The skin site should be clean, dry, and free of hair. Assess the site for irritation. Rotate the site. It's important to document the application site and the removal of the patch. When applying, press the patch for 30 seconds and secure the edges. Write the date, time, and initials on a piece of tape secure on the top of the patch. Never write on a patch while it is on a patient's body. You can also write on the patch prior to putting the patch on the patient. directly on the patch, you want to write the same date, time, and initials, and then apply the patch to the patient's skin. So that is acceptable. When removing the old patch, wash the old site with soap and water to make sure there's no residual medication on the skin. Fold the patch in half with both sticky sides meeting and dispose according to the facility's policy. Eye drops. So here are some key factors. To prevent infection, when using eye drops, you want to make sure you always wash your hands with soap and water before and after applying eye drops. Always apply gloves. Do not touch the tip of the eye drop bottle to your hands or to the person's eyelid or eye. When the nurse is administering eye drops, she will ask the patient to please tilt their head back and look up. With one hand pulling the lower eyelid down, she makes a conjunctiva sac away from the eyeball. This makes a pocket for the eye drops to drop in on the bottom lid. The other hand holds the drop bottle upside down with the tip just above the pocket. Do not touch the eye or eyelid with the eye drop tip. Squeeze the prescribed amount of drops into the eye pocket. For at least 1 minute, have your patient close their eyes. Press your finger lightly in the tear duct, the small hole in the inner corner of your eye. Is called a lacrimal punctum. This keeps the eye drop from draining into your nose. So this technique is called the lacrimal punctum closure method. If you need to use more than one type of eye drop, so two different eye drops are ordered, then you must wait at least 5 minutes between each eye drop. How to apply ear drops. So the nurse would hold the bottle in her hand to warm the bottle for a few minutes because the eardrop solution is quite viscous. Gently shake the bottle. Wash hands, apply gloves. Have the patient lie down or tilt their head to one side. Do not touch the tip of the bottle to your ear because germs can get on the tip of the bottle, causing infection. For adults, you want to pull and hold your ear up and back. For children, you want to pull and hold the ear down and back. This helps straighten out the child's ear canal and allows the eardrops to actually get into the ear. Okay, gently squeeze the bottle to drop the correct amount of drops into the ear. Then place a cotton ball gently inside the ear. Do not push it into the canal. Use a clean cotton ball each time you apply eardrops. Repeat these steps in the other ear if needed. Replace the cap, remove your gloves, wash your hands. So on this slide, we're talking about nasal drops, but I do want to mention that the position of the adult's ear and position of the child's ear for eardrops is very important. So you want to make sure you can distinguish between that, okay? Adult is up and back, child is down and back. All right, so we're doing our basics for our nasal spray. We are also washing our hands and wearing gloves every time we administer a nasal spray. Provide your client with tissue. Ask them to blow his or her nose. Have the client or the patient sit up with their head tilted back. You want to gently shake or agitate the bottle to make sure it's a proper concentration. Insert just the tip of the nasal spray bottle into one nostril. So you're not putting the whole nasal piece in their nose, just the tip. Close the opposite nostril with one finger. Instruct the patient to breathe in gently through the nostril as you are compressing the nasal spray or activating the bottle to release one spray. So the patient should breathe in as you are releasing the medication. Keep the medication container compressed and remove from the nair before releasing. Do not allow the container to return to its original position while it's still in the patient's nose, okay? That is key. And then if you need to do it for the other nair, you will just repeat the process for the other nair. Always cleanse off that nasal spray. I like to just wipe it with an alcohol pad before applying the cap and putting it back in the medication cart, okay? You do not want like germs and things growing on that nasal piece. You're removing your gloves, washing your hands, documenting, evaluating, all of the basics. Okay, so here are a few more tidbits for nasal spray. So you want to have your client, when you spray the nasal spray into their nair, they're going to breathe in and hold their breath for a few seconds, then breathe out, okay, to make sure that they actually get the nasal spray into the nairs. We already said repeat on the other side if it is indicated. I already talked about wiping and cleaning off the nasal, the tip of the nose piece prior to replacing the cap. So you want to tell your patient do not blow their nose after the nasal administration for at least 5 to 10 minutes. Otherwise, they'll just blow the medication right back out. So they may have the urge to blow their nose, but they need to just kind of hold it for 5 to 10 minutes, depending upon the medication. All right, we talked about removing the gloves and performing hand hygiene, documentation, and evaluation of the effectiveness of the medication, as well as you're evaluating for any adverse reactions to this particular medication. So for your meter dose inhaler, if your patient is able to do this particular administration, you can just instruct them and observe. Otherwise, you would need to assist them with this administration. So this is our inhaler, so meter dose inhalers with a chamber. So for our corticosteroid medications, we are always using a chamber. This will prevent medication from being built up in the mouth, causing a fungal infection. All right, so here's our steps. So you want to instruct the patient to open the cap for the MDI and open the cap for the chamber. You want to shake the MDI well. You want to insert the MDI into the open area for the chamber. So the mouthpiece for the MDI goes into the chamber, and then there's a mouthpiece on the chamber on the other end. And I have a sample that I'll show you in class. Place the mouthpiece of the chamber in your patient's mouth. Their teeth should be holding it, and then they should seal their lips around that particular mouthpiece. So you want your patient to breathe out completely as you press the chamber once. Then they will slowly and completely breathe through their mouth only. Hold for 10 seconds. So they're counting to 10 very slowly. And then this allows the medication to reach their lungs. And then they're going to release. So if the patient is ordered more than one puff, they will wait 1 minute in between each puff. So sometimes they're ordered 2 puffs or 3 puffs. So when they are completely done, they are replacing the cap for the MDI inhaler and chamber. Now the canister, MDI canister, needs to be rinsed in warm water weekly. The chamber should be rinsed in soapy water weekly and then rinsed with plain water and allowed to air dry completely before using. Okay, so for a medium dose inhaler without the chamber, the steps are very similar. There's no real changes with the exception of we are not connecting the chamber. But other than that, all of the steps remain the same. Okay, so they are still going to breathe out completely through their mouth. They are still going to inhale as you are compressing the canister once. They're going to hold for 10 seconds, allowing the medication to get to their lungs. And they're going to wait 1 minute in between puffs. And the canister will be rinsed weekly in warm water. So you just do not have the chamber. So the chamber is designed so that they can get an accurate and full amount of the prescribed inhalant into their lungs. And it also minimizes the amount of medication that is in their mouth. So those medications such as steroids or corticosteroids that can cause fungal infections in your mouth definitely have to have a canister. But it is best practice to take the MDI with a canister just to make sure that you get all the medication into your lungs. So what's happening is the medication is going into the chamber. You're inhaling that medication from the chamber directly into your lungs, and it's not sitting in your mouth. Without the chamber, which this slide is speaking of, the medication is deposited into your mouth and then you're inhaling it into your lungs, if that makes sense. Okay, so let's talk about our nebulizers. So our nebulizer is a machine that administers a respiratory treatment. Sometimes in acute care settings, the equipment is connected directly to the oxygen on the wall, and we may not have a actual nebulizer machine. But in a home setting or long-term care or rehab setting, it is a nebulizer machine that you're using. Okay, so the machine must be placed on a hard surface. You should check the air filter, make sure that it is clean prior to using it. If the medication is pre-mixed, which most medications are, you're opening it, you're putting the medication directly into the medication container. If you must mix the medication, you want to place the correct amount into the container. So it may be 2 different medications, and you may need to just put the correct amount of each medication in the container prior to using it. Connect the container to the machine, and the tubing should be also connected to that particular container. Either you can use a mask or a mouthpiece for administration. Okay, so if your patient's awake alert, they may be more comfortable using a mouthpiece and just breathing in and out of the canister. Some patients, even though they're awake alert, they will prefer the mask because they don't want to hold the mouthpiece for 15 minutes. Usually this administration method takes from 15 to 20 minutes for administration. So if they're using a mouthpiece, you want them to make a good seal around the mouthpiece with their lips tightly, and they will just inhale and exhale as they normally would. If you are using the mask, so you're going to make sure the mask is covering both the nose and the mouth. Make sure it's snugly fit, and they will just breathe in and out as they would normally do. Turn the machine on, of course. The patient is definitely sitting upright because that will facilitate the medication getting into their lungs. They're going to breathe in and out slowly through their mouth until the mist is gone. The treatment is over. You will hear the mist is no longer coming out. Sometimes you'll hear this like spitting sound when the mist has ran out. So the nurse will start the administration and check on the patient periodically until the mist is no longer coming out of the machine. So the patient should rinse their mouth with water or saline after each treatment. Rinse the mouthpiece off, rinse the mask off, and they should be allowed to air dry. And if the patient wore a mask, then the patient should be allowed to wipe their face or wash their face off after the treatment. Vaginal suppositories. So you want to make sure the area is clean. You want to make sure, make sure the area is clean. Prior to that, you want to make sure your hands are washed and dried and you have gloves on, okay? And then make sure the area is clean. The vaginal area is clean. You have your patient lie on their side with the top leg bent, or you can have them lie on their back with both knees bent. So you could be inserting an applicator of ointment or an applicator with a suppository. So you want to gently insert the applicator into the vagina as far as you can comfortably go. Press the applicator plunger as far as it goes. This will push the suppository or the cream into the vagina. Remove the applicator from your vagina or from the patient's vagina. From the patient's vagina. If the applicator is reusable, you want to just cleanse it off and store it properly as to facility policy. Oftentimes they are not reusable and they are just discarded into the trash. So then you are going to wash your hands with soap and water, remove your gloves, discard of them in the trash receptacle. Wash your hands with soap and water. Okay. So for a rectal suppository, wash your hands, soap and water, dry them well, apply gloves, cleanse the area, ask your patient to lie on their side, usually left side, but lie on their side with their top leg bent. You are going to insert the suppository. You want the flat end of the suppository at the tip of your finger, and the pointy end will be going into the rectum. For an adult, you are inserting it 1 inch into the rectum, so the tip of your finger will enter the rectum, slightly into the rectum. Then, if for a child, it will be inserted a 1/2 inch to 1 inch into the child's rectum, so the tip of your finger will slightly enter the child's rectum. Instruct the patient to remain still for 10 minutes to prevent the suppository from coming out, and to resist the urge to pass stools for at least 10 minutes or longer if indicated, if it's not indicated for laxative purposes. So actually we have here to not pass stool for at least an hour afterwards unless it is for laxative purposes. Okay, this will allow the medication to be absorbed into the patient's bloodstream. So one of the medications, sometimes Tylenol suppositories are administered for fever, particularly for a child. So we want that medication to be absorbed. So we do not want them to pass stool within the hour. Okay. So you also want to, at the end, you're all done. You're removing your gloves, discarding of them in the trash, or washing your hands, soap and water, drying your hands, and doing all of the basics, documentation, evaluation, and all of the basics. Okay, great.